greetings to all. I am Dr. Madhumitha, Pediatric Dentist. The topic we are going to discuss today is one of the effective preventive strategies of dental caries, that is pit and fissure sealant. The synopsis we are going to discuss today is the history, definition, pit and fissure, type of fissure morphology, etiopathogenesis, rationale behind placing the sealants, ideal pit and fissure sealant requirements, indication and contraindication, classification, clinical procedure, advantages and disadvantages of pit and fissure sealants. So dental caries is one of the most common dental problem that is faced globally, and hence prevention measure for such a problem is inevitable. So caries can either be smooth surface or pit and fissure caries. The smooth surface caries, over the years there is reduction in the prevalence owing to the fluoride application awareness and its practice. But pit and fissure caries prevalence is still on the higher end, accounting to about 90% in permanent molar and 44% in primary molar. Hence, a protective and conservative approach is necessary to prevent pit and fissure caries. So, moving on to the history, right from 1895, pit and fissure caries prevention was being done with various materials, but in the year 1971, Bernard introduced pit and fissure sealant, and the very first introduced pit and fissure sealant was NuvaSeal. So, definition of pit and fissure sealant. According to Simonson, it is defined as the material that is introduced into the pits and fissures of caries susceptible teeth, thus forming micromechanically bonded protective layer cutting access of caries producing bacteria from the source of nutrients. And according to ADA, it is defined as an adhesive material that is applied to pit and fissures of teeth to isolate from the rest of the oral cavity. So, definition of pit and fissure. Pit, according to Ash in the year 1993, it is defined as a small pinpoint depression located at a junction of developmental grooves or at terminals of those grooves. Next, the fissure definition. According to Orbans in the year 1990, it is defined as deep clefts between adjoining cusp. They provide areas of retention of caries producing agents. So now next is the classification of fissure. This classification was given by Nagano, and it has 5 types: U type, V type, I type, IK type and inverted Y type. So the highest prevalent fissure type being the V type, that is 34%, and the least being the inverted Y type, which is 7%. So as you can see in the image given here, U and V type fissures are wide, shallow and self-cleansable, whereas I, K and inverted Y type are narrow slits like opening and deep, which are more susceptible to caries. So next is the etiopathogenesis. So first, evidence of lesion formation occurs at the orifice of the fissure. Next, it appears as 2 bilateral lesions on the opposing enamel cusp. So these 2 lesions coalesce at the bottom of the fissure, and from that they spread laterally into the enamel. So here the fermentation of the sugar takes place by the entrapped bacteria, which leads to acid generation, which causes the demineralization in the tooth. Next is the cavitation occurs. It occurs owing to the loss of mineral, leading to clinically detectable lesion. So next we are going to discuss the rationale behind placing sealants. So high percentage of pit and fissure dental caries is prevalence of high percentage of pit and fissure dental caries occur in permanent tooth. Next, the teeth with deep pit and fissure sealant are susceptible to plaque retention. Immature enamel is more permeable and prolonged eruption time of the molars. So, and the fluoride, one of the main preventive strategies that was known earlier, is effective for smooth surface caries but less effective for pit and fissure caries. So, these are the rationale behind placing sealant. So, indications of pit and fissure sealant: tooth with moderate or high risk of caries, incipient caries lesion, absence of interproximal caries, adequate isolation of the tooth should be possible, tooth erupted adequately. It should be free from gingival or operculum contact. Next, lingual pits of the incisors, buccal and lingual grooves in the permanent teeth are indicated, patient with motor disabilities, patients undergoing medical treatment which may lead to decreased salivary flow, and next for repairing margins of restorations. So having discussed the indicators, now we will see how clinically we can decide whether a tooth can go in for a placement of sealant or not. So the Teeth can be categorized into 3, group 0, 1 and 2. So group 0, that is the teeth can have unstained fissure and there is no catch of explorer. Next is group 1, where the fissures can be stained with no catch of explorer. Next is group 2, where stained or unstained fissure will be there. Some explorer catch but no penetration or sticking of the explorer will be there. So among these 3 groups, group 0 and 1 are considered as non-carious and they are indicated for sealant placement, whereas group 2 is considered as questionable lesion and they are not indicated for sealant placement but can be restored using restorative material, or preventive resin restoration can be done. Next is contraindication. Partially erupted tooth, teeth caries free for 4 years and more, presence of cavitated caries lesion, well coalesced self-cleansing fissures, patient is allergic to methacrylate, presence of interproximal caries, primary molar nearing exfoliation, adequate isolation not possible from salivary contamination, in uncooperative behavior of children. So now we'll see the various types of sealants developed over the years. So pit and fissure sealant is classified into resin sealants, glass ionomer sealant and hybrid sealants. So the resin sealant is further classified based on the color into transparent and opaque, based on filler content into filled and unfilled, based on generation it's UV light polymerized, autopolymerized, blue visible light polymerized and fluoride releasing sealants. Next, glass ionomer cement is divided into conventional and resin modified. Hybrid sealant is divided into compomer and geomers. So ideal pit and fissure sealants, what are the characteristics we are going to see? They have sufficient viscosity to allow sealant to penetrate into the deep pit and fissures, adequate working time, rapid cure, good and prolonged bonding to enamel structure, resistant to wear, karyostatic action, minimally irritating to the tissue. So now we are going to discuss the clinical procedure of placing a sealant. As you can see in the picture, it depicts a clear, clean, deep pit and fissure. So the first is the cleaning and followed by isolation. The cleaning of the tooth, you should clean all the debris from the tooth for proper bonding of the sealant material. Next is the isolation. It is to prevent moisture contamination and enable proper bonding of the material to the tooth structure. Next is etching, rinsing and washing. Etching of the tooth is done using 37% phosphoric acid. It produces a clean, roughened, porous enamel surface into which the fluid monomer can penetrate easily. So microporosities in the enamel surface are created by acid etching techniques, thus producing mechanical lock of resin tag formation when cured. So the timing for etching for primary teeth as recommended is 30 seconds and for permanent teeth it is 20 seconds. The washing time, after etching you are going to wash, and this washing time is 30 seconds for primary teeth and 30 seconds for permanent teeth. And next is the drying time. So it is 15 seconds for both primary and permanent teeth. So as you can see, there are 2 pictures here. In the first picture, the tooth is being etched with 37% phosphoric acid followed by washing and drying. After drying, as you can see in the second picture, you can see there is a frosty white appearance. So this means the tooth is etched properly. So next step in the procedure is application of bonding agent. Bonding agents have been recommended to increase the sealant retention in case of failing to attain proper isolation from the salivary contamination. Bonding agents have shown to reduce micro leakage, improve bond strength and enhance the vertical penetration of the sealant. So next is application of sealant. Thin coat of sealants is applied on all the pit and fissures. So for a maxillary tooth, material is allowed to flow from the mesial side to the distal side, whereas for the mandibular tooth, the material is allowed to flow from the distal to the mesial side. So excess material should be removed before curing. Curing time is according to the manufacturer recommendation. The occlusion, after the curing, the occlusion should be checked and adjusted if necessary. So next step is evaluation of the placed sealants. The sealant is checked for polymerization voids and excess material. Evaluate proper retention of the sealant by pricing off with the explorer. So next is re-evaluation. How we are going to re-evaluate these sealants when they come for the further visits. So sealant retention to be checked and maintained, and if necessary repaired and replaced at every visit. It should be re-examined clinically and radiographically every 6 months. Next is we are going to discuss on sealant retention. Primary teeth retention rates lower compared to that of the permanent teeth retention. This is owing to the direction of the enamel rods, leading to less retention of the material in the primary teeth. So better retention is seen in the anterior teeth, followed by the mandibular teeth and maxillary teeth. Next, clinical expertise will play a major factor in placement of the sealant. Next, uncooperative child leading to difficulty in isolation may have a poor retention. Next, partially erupted teeth, which is difficult to isolate, may again lead to poor sealant retention. Next is causes of sealant failure. Incomplete debris removal from the pit and fissure before etching, insufficient moisture control, occlusal trauma due to polymerization shrinkage. So, advantages of sealant. Placement of sealant is a non-invasive procedure. Sealants will prevent the pit and fissure caries from developing into a cavitated lesion. It is easy to apply sealants. No extensive armamentarium is required. The disadvantages is lack of universal usage, inadvertent placement over caries site, technique sensitive, and caries susceptibility of etched enamel. So, coming to the conclusion, pit and fissure sealant lowers the number of viable bacteria by 100-fold and reduce lesion with these bacteria to about 50%. So, according to AAPD, it strongly recommends to seal and prevent caries. Tooth selection, it is to seal sound tooth surface and non-cavitated lesion, and the patient selection is based on caries risk assessment rather than the age or eruption status of the tooth. So, knowledge and awareness regarding the pit and fissure sealant and the importance of caries prevention should be more told to the parents and the medical doctors, and this is of more prior importance for further usage of pit and fissure sealants. Thank you.